Okay, I'd like to call up our panel for addressing the gaps in serving transplant patients. First on our panel is Tara Toth, Physician Assistant, University of Maryland. And then Dr. Brandon Blue, transplant physician at Moffit Cancer Center. Okay. And then Dr. Vamsi Kota from Georgia Cancer Center. I'm going to let you guys say a few words about yourselves. I'll start with Dr. Kota.
Good afternoon, everyone. Sorry I couldn't join in person, but thank you for having me here. I'm Vamsi Kota. I'm the Director of Transplant in Augusta, Georgia. And good to be on the panel and good to looking forward to the discussion.
I'm Tara Toth. I'm one of the physician assistants. I've been in the cancer center for 7 years here, but in the last couple of years, I found my home in the bone marrow transplant and cellular therapy program.
My name is Dr. Brandon Blue. I'm at Moffit Cancer Center. I typically see patients with multiple myeloma and other plasma cell disorders and see them, kind of before and after transplant, as well as do things like CAR T and other bispecific therapies as well. Happy to be here.
I'm going to open by asking, when you first meet a patient who's being evaluated for transplant, what is your goals of discussion with the patient and their families about stem cell transplant and the risks that they're about to get involved in? We can start with Dr. Kota.
Thank you. And I think one of my main interest is to increase access to transplant. One part of your question is when a patient comes to you, but my main interest is why don't we go to the patient? So I have outreach clinics that I join with physicians, community physicians, and so that way we are in an area where the patient feels comfortable first because I am in their hometown rather than they coming to my city. I think that starts off on a positive note and has a good education that we can provide along with our transplant coordinators calling them back a few days later. Gives them more opportunities to ask questions.
Tara, what your strategy when you're talking to these patients about, the complications, risks, and side effects that they're going to have with transplant?
We're pretty honest with patients. This is a huge thing to go through. We're very honest about all the risks and things that, they have to go through, whether it's infection graft versus host disease. We usually tell them it takes if it's allo, a good year to recover from this. So we kind of like to put that expectation, but we also like to, say that we are there every step of the way, through this. We have a good support system, with the team, and that, we're always going to be supporting them through this. And if an issue arises, we will attack it. We're very proactive. And thankfully, working in a big center, we have a lot of resources for them to get through these things.
Yeah, I think that for me, when I tell patients about transplant, I first have to tell them that it's not a surgery. You know what I mean? So it comes from educating people and kind of letting them know exactly what they're getting into. The thing that makes it very difficult is that even for highly educated people, this is a very complex thing. You know what I mean? And so, health literacy is a major issue, especially for minorities and people of color, or for people who English is their second language. So you're trying to explain something to some people and they probably hadn't been in school in 40 years. You know what I mean? So having to understand biology and cells and it gets to be complicated. So my first, 30, 45 minutes is just literally like, all right, let's take a step back. Because some people, first you got to explain to them their disease, because like they may not understand their disease that you even got to transplant them for. So, I first have to, I really work on education, because it gets complicated. You'd be surprised because I'm like, you've had this for a while. Like, what do you mean? You don't know, and you'd be surprised at things that people tell you when, you say, tell me about your disease. And like, well, and so for me, that's my approach, is more so, you know, let's make sure that you understand. Let's make sure that you understand where you are. I do a combination of talking, and then I also write things down for the patient, because I'm like, when I first sit down with patients, these consultation visits are so long, they probably, who knows what percentage they hold on to. And so I try to make sure that, they take something home, so at least they understand and can reference back and say, oh, yeah, that's right. That's right. And again, like I said, that's why, I think it's important, and we talked about this earlier, is that bringing somebody with them to the appointment is important as well, because, I at the end, I always say as well, I say, well, what questions you have? And if you tell me no, I say, well, you better think of one. Okay. Because there's no way I could just talk to you for 45 minutes. You don't have one question. You know what I mean? And so I, exactly, we weren't fortunate like the folks over in Memphis to get new facilities and stuff. So it's mostly like, do you have a meal ticket? So I need to start asking for that. But yeah, no, I mean, I think that's really a big piece, is important in improving health literacy.
Dr. Kota, you just brought up the access to stem cell transplant, which is something that I struggle with. I get a patient into remission, but then we can't get them to transplant. So what are strategies to try to overcome barriers to access to stem cell transplant, especially in my patients who are coming from underrepresented minority groups?
I think that's certainly a great question, and I think that's where we have to work as a team all over the country to or maybe the world, to work on those things. As I mentioned, I was at Emory for many years, and I moved, well, I guess not recently anymore, 5 years back to Augusta. And Augusta is right in the middle, about 2 hours from many big transplant centers. Outside Levine, Mayo is about 3.5 hours down south. But that doesn't mean all the patients are getting the care they can get with all these big, wonderful academic centers all around them. And so we embarked on our approach to South Georgia, southeastern and southwestern parts of the state, which are extremely under-resourced parts, and patients of all communities, and especially patients of color, are even more under-resourced. So we came up with where we do clinics along with physicians' practices across the state. So for example, today, I'm actually in Athens, about 2 hours from us, from Augusta. There is a large private physician group there. So I do a clinic with them. So when I'm here, I see the patients here, and I can co-manage the patients, have the initial discussions with the patients right here. And that gives them an opportunity to be in their home situation and not necessarily have to travel 2 hours to just hear to me talking about transplant.
That's pretty amazing. How long have you and your cancer center have been going to the local private practice to meet with these patients?
I started this 4 years back. Well, I didn't in 2019, and didn't expect the COVID pandemic, as none of us have. But we are about to start 2 other practices in January, this coming Jan. So we'll be there with 3 or 4 practices from next year. We have shown that we can increase the volume. For example, before we started this, I moved to Augusta in 2018. In 2017, Augusta, well, we're still a small program, but in 2017 they did 40 transplants total. But 2023, we probably will end up around 140. So we went from 40 to 140 in just over 5 years, without a decrease in numbers from any of the other big transplant centers around. So this isn't about taking patients away from one of those sites, or trying to increase our business at the expense of somebody else. Our goal is to increase access, and that's what we are concentrating on.
Wonderful. So this is a question for Ms. Toth. When you're seeing our patients, one of the things I'm seeing is caregiver fatigue as well. And that completely impacts the outcomes that we see in our patients. Do you have a strategy when you're seeing patients on not just taking care of the patient in front of you, but also the person next to them?
Yeah, so I mean, I'm lucky in the fact that we see our patients a lot, especially post-transplant, you're seeing them 2-3 times a week in the clinic. So you really get to know your patients and their caregivers. So I always try and tap into things that I like to find out what makes people tick, what makes them, excited, if they have a sense of humor, if they always like to talk about their dog, like little things that you can tap in to make the caregiver feel involved, make them feel like family. Like I always try and say, like, we're your extended family. We joke around a little bit. We have snacks in the clinic. We just try and make it more because they're there all the time. Mm-hmm. So thankfully we get to build those relationships and include the caregiver. And then, when the patient's well enough to kind of come on their own, their caregiver feels at ease because they know that they're coming to a safe place and that they trust us as their care team because we were able to build those relationships, I think.
Yeah. So Dr. Blue, I'm going to direct my same question that I directed to Dr. Kota about overcoming barriers to access to transplant.
So I'm going to tell you a story. Okay. So when I was at Moffit, I was doing my transplant fellowship. One of the hot things that was kind of up and coming, which Moffit was one of the kind of leaders of, was something called CAR T-cell. It was kind of the hot new thing at the time. And I was excited because what I learned is that African Americans had a worse outcome when it came to one of the indications for CAR T, which is something called diffuse large B-cell lymphoma. So I said, oh, perfect. So now we have this option for people who, have this really bad disease. But then when I was going through the clinics for CAR T, the people who I thought would be at the front of the line weren't there. So what's going on? It didn't make sense to me. So I investigated that. I said, I sent information to every oncologist in Florida, asking them like a little questionnaire saying, do you send patients for CAR T? Yes, no. If no, why not? And then I also sent them a little, let's call it a quiz. I call it a knowledge assessment, but we'll call it a quiz. And it was just a couple questions, And what I found out was the doctors who scored the worst on the quiz were the least likely to refer. And I said, oh, they just don't know what to do. And so the same thing I would imagine is very true for transplant, is that we see people from all over the state of Florida. You guys probably see people from all over the state of Maryland, and probably it sounds like from one of the slides, DC and Delaware and all these other places, but they don't stay in our bubble forever. Like you said, we see them 2 or 3 times a week. That doesn't happen when they go home, And so if the doctors don't feel comfortable of like what to do when they get these folks back, you can imagine some hesitancy with saying, I don't know if this is the right person, even if technically they kind of fit the bill, or fit would be a good candidate. Or, if the person scored worse on that quiz, imagine how the explanation is, hey, I need you to go to Baltimore and get this thing that I really don't know much about, but, I NCCN say you need it, And so imagine how those conversations go. And so I think it's tough, right? I think we had kind of talked about this earlier that, we put a lot of onus on patients to kind of like, patient education. But like I said, I think I'll be honest with you, a lot of work really needs to work on the healthcare as a system and on us as providers, trying to really kind of make sure that people who don't do this every day understand exactly what we do, because a lot of people have no clue when it comes to transplant. So those are the people who are the front line. So those are the people who really are the referrals and sending people to come see us. And so if things aren't, especially like, again, I keep using minorities because that's again, something that I do all the time. And that's my passion. But like, you got to be careful how you're telling Black folks things, you know what I mean? Because they're going to say, no way, and it's all in the presentation of how you kind of tell people about what's about to happen to them. So it's a multi-pronged approach, and it's probably a long-winded answer, but it's a lot of work that needs to be done.
Have you been able to find strategies to educate these community physicians so that you can get those patients to your institution?
Yeah, great question. So what we did was we first had to identify, because what I wasn't sure of is I wasn't sure if people were telling people about transplant and CAR T and them just not coming, meaning that the doctors are saying, hey, you need this. This is an awesome thing. But then the people just not getting to us, or was it just they were never told, so then they're never coming, you know? So it's hard to know where the problem was. And so now that I kind of saw that, all right, if we focus on this kind of provider intervention, then really what we started doing was we have a partnership now with one of the largest private practice groups in Florida. It's called Florida Cancer Specialists. And so we partner now with Florida Cancer Specialists, and we, you know, I won't say thank God for COVID, but like we learned during COVID that you don't have to be in the same room with people to still share really good information, you know? And so we've been able to use things like virtual visits and televisits and things like that really kind of just show them to say, you know, hey, we don't have to necessarily be in the same place. So, you know, I applaud Doctor for going all over Georgia, but we do ours virtually, you know what I mean? And we've been able to show that even just by doing things virtually and explaining things, we've been able to see an absolute referral. So I think it's all, and you know, we're kind of doing similar things, whether it be in Florida and in Georgia, you know, but it sounds like that's the way to do it, is to be right there where the patients are, you know, and again, whether it's on their computer screen or him having these satellite clinics, but really trying to making sure that it's not a local oncologist here and a, you know, a academic or a different doctor or a transplant center here. It's like, hey, no. We here together, you know, we all part of the same team trying to help the same patient. Because again, these blood cancers are very complicated and their treatment is complicated. And these cellular therapies and transplants are even more complicated.
You touched on the collaboration with the local oncologist. For many patients, it's very, very, jarring when you start to actually break away from that main transplant doctor and transition back to the local oncologist. So how have you approached that collaboration?
So, you know, what I always tell people, you know, sports are big down in Florida. So I try to use sports analogies, and, you know, and I tell people, say, look, you know, we're all on the same team, you know, as far as, you know, who's the quarterback, who's the coach, you know, it doesn't matter if we all want to win, and we all want you to win, you know what I mean? And people kind of understand that, you know, and sometimes if it's as little as, you know, showing the patient sometimes like, hey, I have your doctor's cell phone. They have my cell phone. And I show it to them a little bit. I'm like, look, this is your doctor. They can call me. They will call me. And they do call me. You see all these text messages in here? This is from your doctor asking me questions. You know what I mean? And you see how I respond. You know what I mean? Because that's part of it, how we make sure that this collaboration works, you know? And so sometimes that really kind of saves people's fears and trepidations, you know? And so because, you know, we also see people coming back as well for things like vaccines and post-transplant care and those kind of things. And so, you know, I tell people that, like, you know, you could technically get Pneumovax anywhere, but, you know, you come back to see us, that allows you to kind of still stay under the umbrella and kind of making sure that, like, we still have a way of communication and those kind of things. And so I get it. It's anxiety provoking, but, you know, it works. It works.
Questions for Tara Toth. You know, one of the important things that Dr. Hardy brought up was the decline in performance status and how it affects outcomes. How do you approach talking to patients and their caregivers about optimizing their exercise, nutrition, and so forth as you're doing those frequent visits post-transplant?
Yeah, it's challenging. I think, you know, it's something we just take baby steps. You know, we always tell them, like, this isn't, you know, they're like, why don't I feel well? And you're like, you've been out of transplant for 30 days, you know, like, this is not something that you just got some chemotherapy and a couple of weeks later you feel fine. Like, this is a big deal. So we just keep reinforcing that. We're lucky to have amazing nutritionists, and support staff, social workers, dental hygienists who can come and kind of talk with the patients on a frequent basis, check in, making sure, you know, giving them, you know, tips and tricks for taste changes after chemotherapy. You know, we have physical therapists that they can meet with, and we sometimes set up, you know, outpatient physical therapy, or they come to the home. So we try and offer these resources to the patients, and just have continual conversations about how are they doing, what small improvements, you know, if they're taking a walk around their house twice a day, good for them, just encouraging them to push themselves a little bit each day, like telling us how they're truly feeling and what, you know, needs that need to be met for them so we can help them out.
No, I appreciate you for doing that, because one thing that we don't do well in healthcare in general is talk about things like nutrition. things like stress, things like sleep, you know what I mean? Like things that are super important and actually play a huge factor in how people do when they're doing these therapies. Because, you know, a lot of times we say, hey, here's this new medicine, or here's this new, you know, cellular therapy or transplant, here's a haploidentical, you know, we use all these things. But like, you know, what matters to people sometimes is like, all right, you know, am I going to, you know, God knows you're not going to be able to sleep when you're in the hospital. You know what I mean? So what's going to happen when you get out of the hospital? You know, what are these things really going to do? You know, what kind of foods am I going to be able, you know, we talked about graft versus host disease and how that affects, you know, people even just swallowing, you know what I mean? And so, you know, so I'm glad you guys do that, because that's something that we need to highlight more of and kind of just really be honest with people, because, you know, what we call the gut microbiome and really the things that play a huge part of, you know, how you are kind of breaking down food plays a huge role in what your energy is going to be, plays a huge role in kind of how your body is going to react to a lot of the different treatments that are out there. So, so I'm glad you guys do that. That's fantastic.
That's great. And so I'm going to ask my last question, which is for both of you, is what are the things that you have seen that truly has improved outcomes in your patients that you can give advice, especially to people who are considering transplant or patients and their families?
I mean, obviously having a good support system, I think, you know, and just, I mean, and trusting in us as a team and really being honest with us and what you're feeling and what you need from us. I think, you know, a lot of patients are afraid to talk about certain things that are sensitive, and, you know, again, trying to create that family atmosphere to them. I think it helps improve their quality of life and their openness to speak with you, instead of maybe hiding things that might be embarrassing them to them, or they kind of brush off as not a big deal. So just kind of fostering that environment of trust and support from us to kind of, so we work as a team, the patient, us, their caregiver, other specialists, I think helps improve outcomes, because, you know, if they're telling us what's going on and we can act quickly, then we have better outcomes overall.
Yeah, I kind of just want to echo that. You know, I would say for me, I would say the biggest thing is don't come to the transplant consultation by yourself. You know, that is already kind of me saying, all right, something's going on here. You know what I mean? And so I would just say, again, like I said, it doesn't have to be, because again, we know for a lot of these conditions that, especially if you're a minority, a lot of times minorities get diagnosed at a younger age. So, which means you may be still in a working age and not necessarily yet retired, or sometimes due to socioeconomic issues, you have to work kind of post the typical retirement age, just due to a whole bunch of other things called the social determinants of health, which, you know, I know we're not going to get into, but those things are super important. And so I say, all right, well, you know, get the person on the phone, get somebody else on Zoom. We can Skype, we can, you know, use whatever virtual modality possible, because you need somebody else in on this conversation. You know what I mean? And so I would say that alone, not being by yourself for the initial visit, is really a huge game changer.
So Dr. Kota, I will address to you my last question, which was, what are advice that you're giving to patients and their family members in order to obtain the best outcomes of transplant?
I think a lot of transplant centers have good resources available for help, either through social work, financial help. In a lot of organizations like yours and LLS, all of them have resources available. I think unless we talk to people, we won't know about those resources. So it's not something that anyone can go through without help. It is a team effort, and we concentrate a lot on financial aspects as well to make sure everyone gets through this process, this complicated process, as smoothly as possible.